Welcome to Stanford Clinical Lecture Series in Radiation Oncology. Доброго вечора і слава Україні. So here's the slide for Stanford positions. Stanford positions can apply for CME credits, so please stack this number. I put it in a chat as well. Our today's lecture is on radiotherapy for sarcoma, and we have two great speakers, Dr. Anusha Kалбасі and Rik Knoп. Dr. Kалбасі is an associate professor of Stanford Radiation Oncology, and he is also a head of sarcoma service. He has a lab here at Stanford, receiving NIH funding, working on translational research, mostly focusing on developing new immunotherapy treatments for patients with solid tumors and especially sarcoma. Dr. Kалбасі is also an experienced leader in clinical trials related to immunotherapy, CAR T cell therapy, and radiation therapy. And he's also a recipient of Damon Runyon Clinical Investigator Award. So congrats. Before Stanford, Dr. Kалбасі was the chief of sarcoma service at UCLA, and during his tenure there, he was named Next Gen Star by the AACR in recognition for excellence in cancer research. So congratulations, you're such a superstar. And Rik Knopp is our dosimetry superstar. He has many years of experience behind his belt, and he's very interested in global radiotherapy, especially helping developing countries. He visited Africa cancer centers with the Stanford team, and he helped a lot with teaching them treatment planning techniques there. So today he will teach us treatment planning for sarcoma, but first we'll start with clinical lecture by Dr. Kалбасі. So take it away, Anusha. I'll stop sharing.
Fantastic. Thank you, Natalia, for the two kind introduction, actually. I will share my slides and welcome everyone. Thanks for joining us, at least here on Friday at noon. I know everybody's in a different time zone, but so I'm going to talk to you and give you a primer on a rare disease, sarcoma, and the role of radiotherapy in this disease. And so we're going to try to cover a lot of topics, but I'll keep an eye on the chat if there are any, comments during the talk and things that you'd like me to focus on more. I'm happy to discuss and be a little bit impromptu here if it's possible, as much as possible on a virtual talk. So these are the most common types of cancer in the United States, and this is mostly true globally. You can see the common ones are breast, lung, colorectal, uterus, bladder, prostate. These all are tumors that originate from epithelial cells, which are rapidly dividing cells that line our various tracts and ducts and glands and airways. And makes sense, cells that are dividing a lot over time are more likely to accumulate mutations and become malignant as a result of those mutations. On the other hand, sarcoma is a cancer that originates from mesenchymal cells, and these are not rapidly dividing cells. These are cells that make up connective tissue like fat, muscle, bone, and cartilage. And so it doesn't surprise us that perhaps these are less common because these are not cells that are dividing and accumulating mutations. Nonetheless, sarcomas occur, and they occur in a wide range of patients. Sarcoma, the word itself originates from Greek flesh or meat. You may be familiar with other words like the sarcomere, which is a unit of muscle, the sarcophagus, which is a stone coffin that holds flesh, a sarcasm, which is the use of irony to mock or convey contempt or quote unquote tear at the flesh. And in this case, we have sarcoma. So mesenchymal origin, it's in contrast to epithelial tumors, which I mentioned. And today we're going to primarily focus on soft tissue sarcoma. There's a whole other category of bone sarcoma. We'll mention a little bit about it, but not too much. So these are an example of what an epithelial cell looks like on the left, and a mesenchymal cell that looks what it looks like on the right. And these are cells that lack the same kind of connection with other cells. They're more free to move around, whereas epithelial cells are typically more organized and they line various structures. So mesenchymal cell is pretty vague. What is the cell that results in a sarcoma? Which cell in your body becomes the sarcoma exactly? The answer is we don't know. But we know that when a sarcoma occurs, it can resemble certain cells or tissues. And there's usually this progression from benign to malignant that I think is informative to understanding what's going on. So for example, a fat cell, if it were to become malignant, initially a benign, fatty tumor is a lipoma. As it becomes more aggressive, we consider it a liposarcoma or a myxoid liposarcoma. And these are sarcomas that resemble fat. They have features that resemble fat. Doesn't mean it originated from a fat cell, but somehow it resembles fat. Then there's leiomyomas, which are benign smooth muscle tumors, or leiomyosarcomas, which are malignant smooth muscle tumors. And these, again, resemble smooth muscle, but they don't necessarily start from a smooth muscle cell. We just don't have that evidence. And rhabdomyosarcomas are similar to skeletal muscle. MPNSDs, which are malignant peripheral nerve sheath tumors, resemble peripheral nerve sheath. Angiosarcomas, the vasculature and endothelium. And then there's certain tumors like fibrosarcomas or myxofibrosarcomas that resemble fibroblasts. And then there are some that we don't really know what they resemble because they don't resemble anything. It's hard to put them in a basket, and we usually call those undifferentiated, or sarcoma NOS, not otherwise specified. So you can see that there's our characterization of these sarcomas is quite crude. It's based on what they look like under the microscope, and not so much the biology. So radiation is mostly used for soft tissue sarcomas, which here in the red you can see make up about 87% of all sarcomas. There's another 12% or so that are the malignant bone tumors. And those bone tumors are commonly osteosarcomas, which occur mostly in kids, chondrosarcomas, which occur in all ages, especially older adults. Ewing sarcoma, also common in pediatric population. And so those are some of the more common bone tumors. How rare is rare? It's 1% of all cancers. Fourth most common cancer, though, among age less than 20. So kids that do develop cancer, often those are sarcomas. 50%, though, are diagnosed in patients over the age of 60. So it's kind of strange. As a sarcoma physician, you see patients of all ages. You see the older geriatric patients, but you also see the children and a vast array in between. There's about 13,000 new cases a year in the United States and about 5,000 deaths. And just to give you an idea, compare that to about 37,000 pancreatic cancer, 190,000 prostate cancer, and 275,000 breast cancer cases. And this is 13,000 is actually less than the incidence of viral meningitis or pancreatitis, which are not so common either. Where do they occur? Most commonly in the extremity. That's about 50% of the cases in the upper or lower extremity. The next most common are retroperitoneal or intra-abdominal tumors. So, sarcoma is not really a single disease. It's kind of silly to give, have someone like me specialize in sarcoma. There's really 100 different cancers. When I call myself a sarcoma specialist, it feels a little bit disingenuous, because the reality is I'm not an expert in sarcoma, and sometimes I see cases that maybe I've seen a handful of, but I don't think that makes anybody an expert to see 4 or 5 of something. Just to give you a sense that this is really not one disease. This common soft tissue sarcomas that we deal with, that I see in my clinic, liposarcoma, leiomyosarcoma, undifferentiated sarcomas, are the most. And the important ones for the radiation oncologist, I think, are here. Some less common ones I've listed. Things that are often referred to us because of issues with surgical resection or margins, or that often need, preoperative or postoperative radiation. There's some like tenosynovial giant cell tumor, where radiation can be an alternative to surgery when it's difficult to do. And then there's some where radiation is preferred to surgery in certain locations, like a chordoma. And so this listed some of these ones to highlight. And the question is, why do we get sarcoma? The answer to that is also, I don't know. The vast majority are not related to known genetic disorders or familial disorders. They're not something passed down from family. What we do know, though, interestingly and maybe ironically, radiation can actually increase the risk of sarcoma. This was described, over 100 years ago. What is the risk of radiation, sarcoma after radiation therapy? There was some interesting study done last year, published in Lancet Oncology, of about 16,000 women with breast cancer treated in the Kaiser Permanente system, which is a large medical system here in the U.S. The incidence of thoracic scar tissue sarcoma in patients treated for breast cancer over the next 1 or 2 decades was 0.12%, so quite low. But of the 19 patients that were identified to develop sarcoma, 18 of those had received radiation for their breast cancer. So that means the relative risk, it was quite high. It was 8.1. You can see the confidence interval is quite large. But the absolute risk is 0.17%. So even though the risk is clearly higher in the patients getting radiation, the actual risk is still quite low. So I think this is something that's important for radiation oncologists to understand. It's something we should always counsel patients on. These numbers are probably underestimates. Any study that looks at large databases and looking for incidence of sarcoma is likely to miss many of them. And so I would say this is probably a vast underestimate of what we see in reality. But still, I think the number is fairly low in terms of the incidence in the first 10 years after treatment with radiation. There are many molecular subtypes. I'm not going to talk about the biology too much today. It's more of a clinical talk. But this does inform how we categorize these. And I do think about treatment differently for different types of cancers, depending on what is the underlying biology. For example, these fusion-driven sarcomas, especially the ones that have the same fusion partners, like Ewing's gene, they tend to respond similarly in terms of radiation. They tend to be slightly more radiosensitive than some of the other types. So that informs how I go about designing treatment, especially in those gray areas where we're kind of making up the treatment. Which is often the case in sarcoma. Pathologic classification is critical. Having an expert center look at the pathology can change the diagnosis 30 to 70% of the time, and there's even disagreement among specialists 25 to 40% of the time. So that tells you how important it is to get these tissue specimens to a center that is a high volume. There are several immunohistochemistry markers that allow us to distinguish between the different types of sarcoma. I'm not going to go through these, obviously, but just the reference. And then we have to use a lot of advanced tools to be able to diagnose some of these subtypes of sarcoma. So not just an H&E, but an immunohistochemistry and oftentimes FISH to look for chromosomal rearrangement. For example, this is an ALK rearrangement detected by FISH here for inflammatory myelofibrosis. This is looking at copy number alterations, allowing us to help diagnose a case of radiation-associated angiosarcoma. And so these tools are important, which also means they often can take time to do. A week or two for diagnosis is not uncommon. And this is kind of an example of some progression from benign to malignant. I talked about lipoma being an early form of benign tumor related to fat. You can see it looks very much organized. All of this is very fatty, looks very much like normal fat does. But as it becomes more aggressive and more malignant, it becomes more solid. You can see the hazy blue areas here. You can see, and once it becomes a tumor, the nuclei start to look a little bit abnormal and larger. And then once you become very malignant tumor, like a dedifferentiated liposarcoma, very solid, it starts to lose the fatty appearance. And then the nuclei become more and more ugly and irregular, very stable. So this is kind of a normal progression. Pleomorphic liposarcoma is even an uglier version of the dedifferentiated liposarcoma. You can see some of the nuclei are huge, and even more disarray here, and even less looking like fat. So question number one is select the correct statement. The first is, while sarcoma is made of many different subtypes, most sarcoma subtypes have similar underlying molecular biological drivers. The majority of sarcoma occurs in the pediatric population. Pathologists at sarcoma centers will change the outside diagnosis up to 70% of the time, and the most common location for sarcoma is the retroperitoneal trunk. Select your answer. All right. Do we wait for the results or? So
you see the results?
Yeah, it's great. I'm glad we did this question. Good opportunity to review. So even though there are underlying molecular and biologic drivers, they're vastly different between the different cancer types. So and I recognize that one of my graphs may have been a little bit misleading, but that's actually not true. The correct answer was C. The pathologists at sarcoma centers will change the outside diagnosis up to 70% of the time. So that's the take-home message. So sarcoma is very heterogeneous. It's a disease of mesenchymal cells. It's rare. It affects all ages. And that's kind of the take-home. For the first part of the talk, you have to remember one thing: these are heterogeneous disease from mesenchymal cells. They're rare and they affect all ages. How do these patients present? They usually have some painless mass been growing for a while. Sometimes they feel like it's growing very quickly, and I have to explain to them that it's probably not growing as quickly as they think. The analogy I give is that if you had a pebble of sand and it doubles in size, it becomes 2 pebbles of sand, and you don't notice that difference very much. But if you have a golf ball and the golf ball doubles, you very much notice the difference, even though the kinetic of those two things is the same. The doubling time is the same, but it will feel like the golf ball doubling is growing much, much faster. And so once the tumor becomes apparent, they're usually at least the size of a golf ball. So then as soon as they feel it, then it feels like it's growing very, very fast. It was likely growing that fast beforehand. It's just too small to notice. These do metastasize, but they don't typically metastasize to lymph nodes like head and neck cancers or breast cancers or cervical cancers or other epithelial cancers. So these don't usually go to lymph nodes, which is kind of an interesting thing. And they do not present initially with distant metastasis most of the time. So most of the time they just present with one tumor in the arm or leg or in the abdomen. And the question is, what do we do about this, tumor in their leg or arm? So we do an exam. We look to make sure the tumor in the arm and leg is not involving the skin, assess the extent of involvement. Is it causing neurovascular compromise? We look for any history of prior radiation that may have been a risk factor for developing the sarcoma. And then we have to get an MRI of the tumor. MRIs are particularly helpful for sarcomas to delineate the extent of disease because of the soft tissue detail. And then we usually get staging to get a sense of whether the cancer has spread. CT test is usually enough, but there are specific diseases within subtypes of sarcoma where you need to do more than that. You need to at least have an abdomen pelvis or even a PET if that's available. So things like angiosarcoma, myxoid liposarcoma, Ewing sarcoma, rapid sarcoma, these you need a full body staging. And even for myxoid liposarcoma, it's a unique disease, really can metastasize anywhere and has a proclivity to go to the spine. And so some people actually advocate for getting spine MRI because it's hard to see myxoid liposarcomas going to the spine on a CT scan. So a dedicated spine MRI is something we like to do at diagnosis phase. These are just some imaging features. On T1 of an MRI, it looks a lot like, undifferentiated sarcoma looks a lot like muscle. But when you do the T2, especially with fat suppression, you can see it's quite distinct from the surrounding muscle and the subcutaneous tissue. And this is a tumor that's, sitting right next to the bone and invading across the fascia into the subcutaneous tissue. This is quite deep and large tumor. This is a liposarcoma. The reason I have this slide in here on the right, you can see my laser pointer. This material here that's dark is actually all tumor. It looks very much like fat. So just because liposarcomas resemble fat, they also appear like fat on the CT scan. Then there are portions that can become solid. You can see there are some portions that are becoming more solid. So this is probably a low-grade liposarcoma that has grown very large, but then may have certain components of solid aggressive liposarcoma within. This is another liposarcoma that has a more of a solid appearance. We need to biopsy these, obviously, to know what's going on. Nowadays, the core biopsy is kind of the standard of care. When I was training, and a lot of folks were training on it, taught that you needed a longitudinal incisional biopsy. Nowadays, core biopsies have gotten quite good, and pathologists are quite excellent, so that's sufficient. But an FNA is really not the right way to go unless you already have a diagnosis and you're just trying to confirm. But an FNA is not. So what's my prognosis, doctor? And patients will want to know what's going on. The number one thing is what grade of a sarcoma it is. And if it's a high-grade sarcoma, obviously the prognosis is worse. And then there are risk factors for the cancer coming back in the same location, and there are risk factors for cancer spreading to other part of the body. For spreading to other parts of the body, which is probably the biggest concern for patients and for us, is the grade, is the size of the tumor. So, a lot of cancers in breast cancer, head and neck cancer, we think about staging often. The staging in sarcoma is fairly useless. The staging comes down to how big is it and what grade is it. So in my one-liner in my notes, I rarely will put the stage. I just put the size of the tumor and the grade, and that's usually enough to kind of give you a sense of the prognosis. So if it's larger than 5 centimeters and it's high grade, that's not a good. For local recurrence, the extent of the resection, if there's margins that are positive, is a bad sign. And then there's certain histologic subtypes like myxofibrosarcoma that have a very high proclivity for local recurrence. If you're not aware, this is a great app that you can download to give you a prognosis on patients who are first diagnosed with extremity or retroperitoneal sarcoma. You put in this age, size, and grade. As I mentioned, size and grade are the most important, and the type of sarcoma, and then it will give you some numbers. So this is a nice tool, helpful to guide your discussions with patients. And as I mentioned, stage is kind of useless. Basically, stage 1 is low grade, and stage 2 and 3 are high grade. That pretty much sums it up. So how do we treat these tumors? Low grade tumors get surgery alone. We usually don't do radiation. Intermediate and high grade tumors get surgery and usually radiation. And the intermediate high grade tumors that may be difficult to operate on get chemoradiation up front, followed by surgery. And if you have metastatic disease, even you might, if it's a limited amount of metastatic disease, you might even consider radiation and surgery for the primary site, and even radiation for the metastatic. Surgery is the most important thing. A lot of words on this slide. The main thing is, if you amputate, you have the best local recurrence, local control rate. Obviously, we don't want to amputate. So the next best option is a wide excision, and then the less margin you have around the tumor, the worse your local control will be. So the idea is to get the most complete surgery, and this often involves going to an experienced surgeon who knows that you need to be more generous and more aggressive with these tumors than other ways. So surgical margins matter. This is another slide to just reiterate that, but radiation, which is what we want to focus on here, can be given in 2 situations, before surgery or after surgery. And it's really a dealer's choice at this point. We, in academic centers in the US, tend to favor preoperative radiation because we think the long-term side effect profile is better. Because, frankly, it's easier for the radiation oncologist to treat before surgery. We have a tumor we can aim at. It's easier to contour. It's not so much guesswork. You don't have to worry about, are you covering the edema or the postoperative inflammation or not? It's just a lot more clear what you need to do. And so I think that is an important thing, and it's important for the patients as well, because when you're not sure, you end up treating more and more to cover for your uncertainty. And so the patients in the postoperative setting end up getting larger radiation fields, and that's probably why they end up with worse long-term toxicity. Amputation used to be the standard of care. Now we do limb-sparing surgery and radiation, and that was shown to have the same survival, and that's why we do it. I'm not going to go into that too much, but basically, with limb-sparing surgery and radiation, the survival was the same as patients who got amputation. The local control was a little bit worse, but that's okay because these patients can get amputation later if they really need it. So you save a larger number of patients from amputation. And amputations are really reserved for unique scenarios now. Now, what about just surgery? What about just avoiding radiation altogether? Well, it turns out if you don't do radiation, the local control is significantly worse, especially especially in more aggressive high-grade tumors from this trial of brachytherapy memorial decades ago.
Реально классный пацан. Я с ним общалась не один раз.
And then
Прям очень такой правильный.
mute.
Сам для себя может ответить. Очень.
In a separate trial of external beam radiation, again, a randomized trial, doing radiation improved local control in both high and low-grade tumor. But I want to emphasize, radiation does not change survival. So people have looked extensively, no matter how good your local control is after radiation, does not impact survival. And the reality is, because if somebody has local recurrence, ultimately they can have an amputation. And what drives survival is the metastatic disease. And radiation does not impact the development of metastatic. So we need better systemic therapies, really. So there are situations, though, where you don't do radiation, even for a high-grade tumor. So that's down here. So we know low-grade tumors, you can avoid radiation in a lot of situations. But intermediate and high-grade tumors, if they're small and superficial, and small is kind of subject to interpretation, but tumors less than 5 centimeters or even 3 centimeters, surgery alone can result in very good local control of 90% or higher. That doesn't mean radiation wouldn't improve that, but do you really need to go from 93% to 96%? Probably not. And so if you're already at 90% local control, I usually don't offer additional radiation. My threshold personally is close to 15 to 20% risk of recurrence when I would offer the radiation therapy. What are the side effects? Why are we even thinking about omitting radiation? If you do radiation before surgery, patients can have wound healing complications, and in the long run, their extremity, especially if we're doing extremity radiation, can become edematous, fibrotic, and they can lose range of motion. And this happens in about 10 to 15% of patients historically, although these numbers are getting lower with modern techniques. The rate of bone fracture and peripheral nerve injury is quite low, but these are also theoretical risks. And so these are the reasons why, if possible, we'd like to avoid radiation. And as we talked about pre-op versus post-op, this is kind of a summary and why I think pre-op is better. But there was actually a randomized trial that answered this question 20 years ago, and it was comparing patients getting pre-op radiation versus post-op radiation. The dose post-op is higher, 60 to 66 gray, compared to 50 gray pre-op. But the patients getting pre-op had much higher wound complication rates, as we already know. So this was the primary endpoint of the study, and this confirms that radiation before surgery makes surgery more complicated. Post-operatively, the patients have more acute skin toxicity, but these things heal. And the important thing is that at 5 years, the local control and the survival of these patients was essentially the same. So getting post-op radiation for sarcoma is perfectly acceptable. Pre-op radiation is also acceptable. They both have the same outcomes in terms of disease control. The main difference is if you do pre-op, your risk of wound complications is higher. If you do post-op, we found that the risk of long-term complications like fibrosis and stiffness and edema tend to be higher. We talked about that a little bit earlier. So how do we design our treatments? We take the tumor and we draw an expansion around that about a centimeter and a half. And then I like to draw, and I'm going to show you a picture of this. Sorry, jump around a little bit, but the radial expansion is shown here. It's 1.5 centimeters on the axial plane. I do this all the way around. The longitudinal expansion, which is supposed to be 3 centimeters, some people will use an automatic expansion to do this. I don't like to do that. The reason being is because the soup expansion doesn't necessarily track in the same exact direction that the muscle bundle is going or that the tumor was tracking. The tumor is often at an angle or maybe in a unique position. So the longitudinal expansion I like to do manually for 3 centimeters. So we do a 3 centimeter expansion longitudinally, 1.5 around. Then we aggressively crop out of anatomic boundaries. For example, in this case, the tumor is white. 1.5 centimeters, you would definitely stop before you get to the bone because the tumor is not involving the bone. Also, if the fascia, the muscle fascia is here, we would crop out of the muscle fascia because the tumor is not invading into the subcutaneous tissue, so there's no reason to extend it beyond that. Even we consider cropping between muscle groups. So if there's fascia between the muscle groups that the tumor is not involved with, we would crop the CTV out of that. And then we add a 0.5 centimeter expansion for CTV. And that's the contouring for preoperative radiation for the extremity or trunk. In the trunk, it's a little tricky because there's it's harder to say what's longitudinal and what's radial. So we typically do a larger longitudinal expansion. So I'm going to go back here. So these were the contours, and where we get these are from RTOG 0630, which actually was using smaller volumes than previous studies and showed that the local control was just as good. So they only had 5 local failures out of 73 patients, so 7%, and all of them were in the field. So it wasn't because they had reduced the field size. And this study was also important because it used IGRT, and it showed that IGRT is important in order to restrict your PTV size to 5 millimeter expansion, because the shifts were anywhere between 1 and 1.5 centimeters using CBCT or MBCT or KB exact track. So for that reason, we do IGRT for these cases. I typically use for my cases. This is some data to show that IMRT can be used to spare the tissues surrounding the tumor that are important in reconstructing the site for using rotational flap. So in collaboration with surgeons, they spared the virtual flaps that the surgeons were going to use to heal this area. And they showed that primary closure was more possible more often using IMRT technique. And there have been several studies now supporting the use of IMRT for soft tissue sarcoma. And you can see, compared to the 3-dimensional era, our rate of grade 2 and higher soft tissue toxicity is much lower in the IMRT era, shown down here, and even lower than 5 to 10% in the most recent studies that have been published, including the study from MD Anderson a few months ago that showed that they had even less than 5% grade 2 or higher. There's also a lower risk of local recurrence associated with IMRT, lower risk of femoral fracture in 2 separate studies. And so for these reasons, we like to use IMRT when possible. Obviously, it's not always possible, but it's our preference. We showed these slides already. In the post-operative setting, it's a very similar kind of expansion approach. The difference is that you don't have a GTV, so we use a preoperative GTV from the MRI. And we also use the postoperative cavity as the GTV. And we make sure the CTV covers any postoperative edema, and that's where it gets a little tricky, as we talked about earlier, because it's a little bit of a gray area. And so volumes tend to be a little bit larger. These are some of the structures that we constrain. We'll talk about the planning with Rick a little bit later. But the key things being the longitudinal strip of skin, the joints, the weight-bearing bones, the femoral neck and the head, and the skin itself, which we draw as a 5 millimeter circumferential thickness. And then some people get preoperative radiation and then they have surgery and then there's a positive margin. And the question is, should we give more radiation now that they have a positive margin? People used to do this frequently. My preference is not to do this. I think the data that suggests, the data questions whether or not this is effective. And biologically, it doesn't make a lot of sense. You had surgery, you've already had radiation. Now it's 4 to 6 weeks later, and you want to give 10 to 16 gray. We know 10 to 16 gray is not going to do anything to viable tumor. So if there's really viable tumor left, this is not going to do it. And so my preference is to save the radiation if the patient has a recurrence, and you can give them a real dose to do that rather than doing 10 to 16 gray, 2 months later. So here's our second question. I'll read through these while you think of your answer. The rate of local recurrence. Oh, and this is to select the incorrect statement. So one of these is not right. The rate of local recurrence after surgery alone for a high grade but small and superficial soft tissue sarcoma of the extremity may be less than 10%. For patients who have preoperative radiation and surgery who are found to have positive margins, a post-op will reduce the standard of care. preoperative radiation for extremity soft tissue sarcoma is preferred to postoperative radiation, in part because it's easier for the radiation oncologist to contour. Without image guidance, PTV would need to be at least 1.5 centimeters to account for daily setup variation. All right. Like most people answered correctly, that the postoperative boost is not standard of care. But the rest of the statements are correct. All right, moving forward. So I'm going to talk a little bit about alternative fractionation regimens, which is the area of research that I've been involved with for preoperative radiation. So for decades, actually extending back to the 1970s, at UCLA, there's a group that led by Fred Albert that started this preoperative radiation regimen that was a shorter regimen of 8 to 10 fractions, where they intercalated combined chemotherapy, adriamycin-based chemotherapy. And they tried a few different strategies, but they landed on 3.5 times A-gray with cisplatin and ifosfamide, and later with adriamycin and ifosfamide. And they published this, and it was adopted by several institutions as kind of their standard approach for some of the high-risk soft tissue sarcoma. But when we reviewed this data in 2016, we found that of these 122 patients that had this regimen, the local control was actually kind of low. It was 84%, which is less than the bar that is closer to 90, 95% for conventional radiation. And so we started to think there may be room for improvement. And so instead of this 8-fraction regimen, we developed this 5-fraction regimen of 30 gray and 5 fraction, which is supposed to be equivalent to the 50 gray, whereas this one is a little bit lower than 50 gray. And since then, there's been several groups that have published on this. There's a group in Poland that had published on a slightly lower dose of 5 gray times 5. We published on our 6 gray times 5 experience. Cleveland Clinic had a small series. And since then, Medical College of Wisconsin has finished their study. MD Anderson has finished their study. This needs to be updated, but it's funny. I updated it on the talk I gave this morning, but I forgot to update it on these slides. But so the take-home message here is that with the 5 gray times 5 used by the Polish group, the local control is still a little bit inferior. But once you get to 6 gray times 5, the local control seems to climb up, and the Wisconsin group had 100% local control in their 32 patients using 7 gray times 5. And the major wound complications seem to be on par with what we see with conventional radiation. So this is the UCLA study. Again, patients have biopsy and imaging, and then they get 6 gray times 5, and then they have surgery. The great thing is they don't have to travel very far for very long. If they're traveling a distance, it's short, it's very convenient. And here are some of our results. This is about 109 patients now. As of about a year ago, it's now closer to 130. And these patients are of all ages. You can see range from 17 to 90. Large tumors are included, about 10 centimeters average size, and these are the histologies that the great thing is that patients love this regimen, and we were able to accrue very quickly. And even in COVID, when patients were avoiding the hospital, our accrual did not stop. And then patients started to travel from larger and larger distances to come get this treatment because of the convenience and because patients want to be treated at a high volume center with experienced physicians, physics, dosimetrists, therapists, and if they can do it this way, then that's a huge advantage. Wound complications have been similar to what we see with conventional 5-week radiation, about 25 to 30% with our study. The one concern I have about wider adoption is that the patients that do have a wound complication, the wound seems to take a little bit longer to heal. And I don't know if this is unique to our, experience at UCLA. And so I'm really looking forward to getting results from my colleagues around the country that have opened a similar study. And we just opened the study at Stanford, approved by the IRB yesterday. So hopefully we'll develop some of that experience here. But this is a concern, and something that I don't think means that we can't do this approach. It's just something you'll have to counsel patients on and say, you know, if you want to do 5 days of preoperative radiation, that's fine, but just beware, if you do have a wound complication, you may have to deal with it for a few months longer than otherwise. MD Anderson just published a 3-week 15 fraction regimen, and they had excellent results, really outstanding study. But the question becomes, you know, what to do here? You have 1 week, 3 week, 5 week, what's the right regimen? And so we're in discussions of doing a large randomized trial to sort this out. My gut is that in the end, it's going to be a little bit dealer's choice and patient preference. You may accept slightly higher risk and do 5 days. You may want to take it safe and do 3 weeks. In my opinion, if 5 days is the reason you get radiation at a major center, I think it's better to do it that way than to do it 5 weeks at a place that doesn't necessarily have the same experience. There's also some dose tailoring so moving away from fractionation. We use, 50 gray in 5 weeks standardly. That's what we use for all sarcomas. But if you remember at the beginning of the talk, I told you we have 100 different types of sarcomas, but we use the same radiation dose for all of them. How is that possible? How are we so far behind, biology? And the reality is we're catching up. And there are some tumors like myxoid liposarcoma where we know now they're extremely radiosensitive. So there's a phase 2 study that used 36 gray and 18 fractions, which is quite a bit lower than a standard dose, but their local control was 100% at 2 years. So in this disease, you can use a lower dose and have, at least early on, equal results. Now, are we doing this routinely? I mean, it's only 2 years of results, but it's biologically sound and it's consistent with my personal experience. So I think this is something that, again, with discussion with the patient, can be considered on a case-by-case basis. And then there's definitive radiation for unresectable disease. So there are situations where surgeons will tell you that they cannot operate. And it depends on which surgeons you ask. But, and I think you should always ask more than one surgeon because surgeons will have different opinions on what is resectable and what is not resectable. We had surgeons at UCLA like Fran Hornacek, who is now at Miami, who is, famous or infamous for his willingness to try the craziest pelvic resection. And in the eyes of some patients, he was a hero because he was able to remove tumors that nobody else thought that they could remove. But then again, sometimes when you're brave, it results in very complicated post-operative courses. And so it's a balance. So there are situations where maybe definitive radiation is the way to go. And then how do we decide on that? And how do we counsel patients on what is the success rate? The fact is the data is very limited to individual series from institutions that are usually small numbers of patients using very heterogeneous doses, and it's not very controlled. And you can see the local control ranges from 5 to 70%. And in modern series, it seems like the local control with definitive radiation is somewhere around 50 to 60%, which is not great. Obviously, we get 90, 95% with surgery and radiation. So 50 to 60 is kind of low. But then again, that means 50 to 60% of patients who otherwise would not really have a surgical option are having an option to have long-term control of their tumor, which is not bad. So I think it can be considered. We usually want to get doses in the 66 to 80 gray range. So this can be challenging, obviously, depending on anatomically where we are, especially if it's in the pelvis, near the neurovascular bundle, sacral plexus, and things like that. So there are complications that we have to accept. But surgery also has complications. So especially if it's an unresectable tumor. So this is something we have to weigh. We had a talk from Dr. Timmerman, a couple weeks ago at the research retreat here. And the reality is, we write constraints, but if we don't treat the tumor is going to destroy those organs at risk. And especially in these cases where there's no surgery, if radiation is not sufficient to control the tumor, then the tumor will destroy the nerves. And so I think we have a little bit more of a license to be aggressive in those situations. There's questions about whether you can combine radiation with RFA or cryoablation. In my opinion, these haven't really been rigorously tested. RFA and cryo are typically used for small benign tumors. I don't know if it makes a lot of sense to try to do both at the same time. It would be hard to prove that there's a benefit. I prefer to do the radiation and save the cryo and the RFA for recurrences that happen afterwards that can be managed with those procedures. But the last thing I want to emphasize is in sarcoma, there are zero curative systemic therapy. This disease is uniformly fatal when it's metastatic. The response rates to chemo are abysmal. The drug development is slow, and biotech and pharmaceutical companies have very little incentive to develop drugs for rare diseases like sarcoma. And patients ultimately die from metastatic disease. I want to show you this graph at the bottom right. This is a really sobering graph. This is doxorubicin. This is the standard of care. This is first-line chemotherapy. This is what patients get when they get diagnosed with metastasis. This is the best that we have. And this is progression-free survival. And, you can see within 12 months, 80% of the patients have progressed. This was a trial where it was a drug that was promising in phase 2, and they did a randomized phase 3, and clearly the drug is ineffective. But when this is what patients have from systemic therapy standpoint, then we obviously have to do better, but this means that there's a role for radiation for sarcoma in the metastatic setting. And there's a few different situations I want to highlight. One is a patient is getting chemo and they respond well, but then there's one lesion that's progressing. This is a great time because there's not a lot of drug options for these patients. Treat this lesion with radiation, allow the patient to continue on the drug and benefit for as long as possible. Another scenario, patient gets chemotherapy, progresses. This is doxorubicin. It's really toxic. Patient is super sick. You give radiation to these sites of disease, and that gives the patient a break. They can be off of systemic therapy for 3 months. They can go back to enjoying their life a little bit, and then they can start the next systemic therapy once the cancer progresses. And then finally, maybe you have an elderly patient has only one side of metastatic disease. Doxorubicin would make them very sick and maybe even kill them. Maybe you do radiation instead of doing chemotherapy. And maybe it takes them another year to develop the next lesion. And then maybe you treat again with radiation. I've had patients where they had metastatic disease and we avoided chemotherapy for 4 or 5 years. And this was a 75-year-old person. That means between 75 and 80, they were able to live without having to suffer the side effects of chemotherapy. So I think when you acknowledge this scenario where systemic therapies are really not effective, you have to be more creative about how you use radiation. I'm going to stop there because I want to give Rick time to present his slides. There's a few other slides here, but I think I hit most of the key points that I wanted to give. I just want to highlight the disease site team here at Stanford that are taking care of sarcomas, along with the therapist, dosimetry, physics, and everybody. So thanks for your time, and happy to take questions at the end after Rick's.
Excellent talk. Thank you so much. You explained so well, very logical and accessible. Thank you.
Okay, hopefully you can see my slides.
Yeah, we can see them.
Okay, so we're going to go into treatment planning of sarcomas. And hopefully it will advance for me. There we go. So this presentation, we're going to look at simulation and immobilization, fusions and contouring of OARs, and then treatment planning for 3D and for VMAT. And to start with, looking at the area that we're going to be treating, if you're doing an extremity like a foot, a hand, or if you're doing head and neck, aquaplast is really a good way to mobilize the patient. If you're doing a hand, it's kind of nice if you can get the hand above the head. And when you're doing a foot, it's really easy to get the other leg out of the way. So these are great ways to mobilize. When you're doing chest, abdomen, pelvis, arms, back lock pegs are very helpful for immobilizing. And if you're doing the arm, it's nice to get the arm away from the body and as high as the body as you can. That gives you more angle to bring in beams and miss the body. So those are ways of avoiding it. And then finally, like we said, most of them are extremities, so great majority are legs. And so the best way to do it, like this version here, if it's, you know, lower thigh and then to the tibia, if you can get that leg up higher and immobilized, you can get more beams in, a better VMAT plan. And when you're doing thighs, it's really important. This one's a little different. We had to do a frog leg on this. There's two legs in here. But if you can keep the affected leg straight, frog leg the other side, and with men, it's nice to be able to get the genitalia up and out away from the affected side. It's going to give you more room to bring in the beams. And again, backlocks are great for this. Then we're going to get into fusions. And like Dr. Kalbasy said, MRIs are great for fusions, especially in pre-op. But we can also use PET scans. And I'll show you, when you start a fusion, it's really easy with the PET scan because you have a fusion CT and you can align bone to bone. And then you can tweak it for the muscle compartment. MRIs can be a little bit different because they're always in a different position from planning to the actual MRI acquisition. So I always like to start with the bone. Align the bone up, then you can start to align the compartments of the muscles up. That may throw the bone off a little bit, but it's more important to be aligned to the actual tumor bed and muscle bed. And it just gives a better delineation for the doctor when it comes time to draw that tumor. As you can see coming up.
And Rick, I'll add that, you know, there are many cases where, you know, despite our best efforts, we can't really get a reasonable fusion. And so I you know, rely on anatomic boundaries and landmarks from the MR and just do the contouring side by side rather than.
Yeah. Especially if it's like a posterior tumor and they've been supine in the MRI and we're treating them prone. That's changed the volume quite a bit. So
the other thing that we've done is when I was at UCLA, we had the MR Linac. We would use the MR Linac to do SIM in the same position. And we would register the MR Linac SIM with the PT SIM, and that would give us perfect registration of the MR.
We can do it here, right?
Yeah, it takes up time. The problem is it takes up time on the MR that, you know, but we should talk about doing that potentially, especially if the MR has a few open spots.
Definitely.
yeah, it would be nice. We could set, you know, set a certain time of day for these, but I think it's going to be a great extension of our treatment. So that's kind of the fusion. For contouring, it depends on where we're treating. You're going to contour the OARs, the normal structures for the region you're treating. But one important thing when you're doing extremities is to contour the joint space. You're not just contouring the bones above and below the joint, but actually including the joint space in between. I kind of showed you what we do here, and it's really nice to look in the coronal view because you can see the bones, but you can also see now the joint space in between, and we can put that joint constraint on that was V50 less than 50 gray, if we can, unless it's in the joint. But it's things that you have to think about when you're doing the plans. And then 3D planning. Sometimes this is the easiest way to get to a tumor. So it's just a matter of taking your beam, maneuvering it to see where you can spare the most tissue, spare the bone if possible, and bring in that beam to treat the tumor. So this is just kind of moving the beam around in the eclipse system, seeing what's going to be best, sparing this area over here. Unfortunately, this tumor includes the bone. It was very, very, very close to the surface. So in the end, we came up with a beam that is blocking what it can. This is skin, this is all air, so we're getting the tissue. And this is what the plan looked like. So we're sparing the bone as much as we could in the knee, but we're also sparing this area of lymphatics, which is going to play a part when they go in to do the surgery. Like we said, lymphatics, that edema can be very devastating in extremities. So that just kind of gives you an idea of just simple. With this, we did a field and field technique to minimize the hot spot, make a nice even dose around that whole volume. VMAT extremity. This is a thigh, quite a long tumor. Used 3 different fields, 3 different partial arcs. This is what it looks to optimize. But as you can see, I've also put on some constraints. So I have a constraint for the unaffected leg, which we try and keep dose out of, but it's not, we are always going to have spillage over. So we just try and keep it as low as we reasonably can. But the important one is keeping that strip here where we can keep the dose below 50%, and that way we're sparing that lymphatic drain again. And that will help when it comes time for surgery and the long-term effects. And this is what that plan looked like. So you can see the strip that we're trying to spare. See the 50% coming down. It's doing a nice job. Plus, you have to look at genitalia when you're doing this, trying to keep that dose down, but just really trying to keep the dose around the tumor, trying to spare the bone and that strip as much as possible. And you can see the disease in here. Okay. Then we did, this is a synovial sarcoma, which again was kind of a rare one. This patient was a chest and abdomen. It was actually quite high up into the chest and all the way down around the kidney. So this is just some of the optimizations we did for it. It was a boost with inside the volume. And so we had a 60 gray and a 50 gray. And this is what that plan looked like. As you can see, it's starting up in the chest and coming down and wrapping around, trying to keep the heart dose as low as we can, spine dose as low as we can, skin dose as low as we can. And then we get down into the stomach area. So we're trying to keep it just very, very nice and tight, coming down into the kidney.
These are awesome.
Thank you. I did all these plans. Yeah, so that one was quite a challenge because of where it was and everything. And then a VMAT head. This was, I can't remember what sarcoma it was, just at the top of the head. So we had to use a bolus because skin was involved. And so I did a 3-field plan, 2 arcs, and then a sagittal arc. And this is what it looks in the axials. So you can kind of see this is the boost area. We're treating all the way around, but trying to spare the brain as much as we can. That's the 50% line. But what I like is showing it in the coronal because you can see how it just breaks around the brain and is treating that area. And then this is the boost area there.
The other tool I really like in these situations, but we don't have here, is Tomo. Tomo does a really, really nice job carving around the superficial scalp.
We can also use reflection, so it's kind of like Tomo. Yeah.
You know, actually, I think this would be a good plan to send back and look and see what reflection could do for it.
Yeah.
Yeah, I've heard this, that reflection is like Tomo. I don't really understand that exactly, but you'll have to explain it.
And this is a good size for that one too. It's not a long tumor, so the time won't be super long. That's the issue with reflection is the time.
Yeah, and tomo you can treat larger field sizes.
Right, right.
The same with reflection. Mhm.
I thought
I
it was
didn't-
limited by field size.
Well, the maximum is 50 cm, so hopefully that's okay. Is that okay?
It depends.
I could have included when you do have field sizes that are beyond that 40 in the variance situation, you can do a 2 ISO plan in Eclipse and treat that tumor, but then you just have to break them apart for the actual treatment. I've done that quite a bit in the past, but I think with pre-op, we aren't seeing tumors quite as long as we're in post-op. We're including, like you said, more volume because we aren't sure of the margins. And that is all for me. So now it's question time.
Thank you so much, Rick. So opening the floor for questions.
Everyone, thank you very much for the brilliant session of the sarcomas, because it's every time challenging localization, and it's quite rare tumors, and from time to time we have doubt about the contouring and treatment strategies. So thank you very much. My first question about lymphatic path, and I've heard some answer, but in case when the lymphatic path is too close to the main mass of the tumor, could we avoid it, for example, crop from the CTV, or decrease the dose to this area, because after the treatment, the patient would have edema recently, for example?
I have not done that. I think if the tumor is, for example, let's say you have an inguinal, proximal thigh tumor near the inguinal. Now, are you talking about the lymphatic drainage to the lymph nodes in the inguinal canal? I don't crop less than the standard CTV for the lymphatics, because that's a common area of direct extension. Even though the tumors don't spread to the lymph nodes, they can directly extend there. So unfortunately, in those situations, the risk of lymphedema is just higher. So
thank you.
We accept that risk.
Mm-hmm. And another question about tumor thrombosis. In the nearest vessels, it's could be close to the big mass, but quite far away. And do we need to include it into the GTB, or it's enough to be included this area in CTV, PTV?
So I missed what the beginning.
Tumor thrombosis.
Thrombosis. I see.
Yes.
It depends on the situation. So you're talking about, for example, extremity tumor with the thrombosis, or like a retroperitoneal?
Extremity tumor. It's upper femoral vessel. Area with vessel. So
first of all, sarcomas are unique. Unlike carcinomas, the rate of DVTs associated with sarcoma is quite low. Tumor thrombus is also uncommon. That usually, if it happens, it's at the same site of the tumor. So you're talking about a tumor thrombus that is separate from the tumor?
Yes, it's like separate, but very close to the big mass of the main tumor.
Yeah, that's a little bit of an unusual situation. I mean, I think if it's close enough, then I would include it in the CTV. But I would question. Sometimes a PET CT could be helpful, because if it's not lighting up on the PET CT, it could just be a bland thrombus related to the mass rather than a malignant thrombus.
We discussed actually this situation with our radiologist, and they suggest us to include it into the treatment field.
Yeah, I mean, I think if it's close enough, the cost is worth the additional volume.
Okay, thank you. And maybe the last question, maybe it's not precisely your field of the interest, but maybe, yes, about diffuse type of tenosynovial giant cell tumor. It's not sarcoma, but it's...
We see these. It's very, here it's very center dependent. For example, at UCLA, we rarely use radiation for TBCCs. It was usually surgery or the new agents, CSF1 receptor agents that are used that can be effective for these tumors.
Yes,
at Stanford, though, radiation, can be effective in multifocal disease, and you only need 36 gray or so. So I think it's a useful tool.
And 1.8 per fraction, yes? Those 1.8 per fraction. Okay, thank you. We use it only in case of the relapse after surgery and after a lot of surgeries, for example, or in complete surgery. So in case of knee localization, it's very useful. Okay, thank you very much.
I think it's reasonable.
There was also a question in the chat.
Yeah, I saw that. So we talked about this. I very rarely use a postoperative boost. I say if I really believe that there's a chance that the tumor is going to come back, either we have to do another resection, and if another resection is not possible, then I monitor the patient closely, and then you save the radiation for when they truly have a recurrence, because then at least I can target my radiation to the right area and I can use it.
And the second question is about hyperfractionation.
Yeah, I don't use the hyperfractionation except on clinical trials. So I should have emphasized this, that this is not something I do routinely. Now I understand in some situations, it's hard to run a trial. And there may be situations where you need to be flexible. So I think you need to have that discussion with the patient that there are risks. And, the other thing is the surgeon needs to be comfortable, because there are some differences in the surgery after 6 gray times 5 than 5 weeks of radiation. Our surgeons, develop an experience with it. So it's not something that should be done routinely without some thought and consideration.
Another question, what about tumor growth swelling during treatment?
That's a great question too. One of the issues that pops up, a lot of these tumors can bleed into themselves and hemorrhage, and that could cause sudden tumor changes. Sometimes they can grow at the beginning of radiation therapy a little bit. So I think resimulation is a common thing for sarcomas. So you have to be prepared to do a repeat simulation and adapt the treatment. But I don't think there are many situations where a tumor is truly radio-resistant that you would not be able to stop its growth with radiation eventually.
Anusha, I have a question about hypofractionation. So it's quite intriguing. It's much more convenient for the patient, obviously, 5 fractions, right, versus 5 weeks. And the question is, how frequent are actually post-surgical complications, like to weigh the risk?
The same. So far, the frequency of the post-surgical complications is the same as what we get with 5 weeks. It's about 25 to 30%.
Okay.
But of those 25 to 30%, it seems that 10% of the patients have complications that seem to drag on for 6 months or so. And so I don't know, and that's again one institution, one series. Could have been our surgeons there are less likely to use plastic surgery for reconstruction. So there are other factors. So I don't know if it's actually worse. It may not be. But the main point is that it's a little bit of a unknown area, so it's difficult to offer it to patients without studying it carefully still.
Yeah, excellent. And so we are just opening the trial here, right? So we'll
Yes,
be doing
right.
seeing that fractionation.
Yes,
Awesome.
in the next couple weeks.
Excellent.
Congratulations on that.
Yeah,
Thanks.
very good. Any more questions? Thank you
Thanks
so
for your
much. That
attendance.
was excellent session. Thank you.
Fantastic.
And I would like to mention next week we will skip a Wednesday lecture because everybody will be at Astro here in US. So we'll resume on Friday. See you next Friday.
Natalia, do you guys do evaluations for these?
We'll do it at the end for the whole course. Yeah, but excellent work. Evaluation is just 2 thumbs up.
Thanks,
Thank you
Natalia.
so much, Anusha. Thank you, Rick.
Bye.
Great work. Thank you.